Okay, so refresh and okay. Yeah, no? Refresh your screens. All right, so great. We are back, I think. All right. Okay, so let's see this here. We were discussing. Okay. All right, so let's see. Let's continue from where we left. All right, so we were discussing the slow pain and the fast pain pathways, and I told you the one of the characteristic feature of the slow pain pathway is that it gives a number of collaterals, like for instance reticular formation, periaqueductal gray, periventricular areas of hypothalamus, but the pathway gives no such collaterals. One another difference between the fast and the slow pain pathways is, if you look at the cross section of the spinal cord, right? Cross section of the spinal cord, yeah. No, beta. Serotonin, Shubhangi Agarwal, serotonin and norepinephrine are not neurotransmitters for pain. See, they stimulate the reticular formation. Reticular formation, there are two areas in the reticular formation, which is raphe-magnus nucleus and locus coeruleus. Raphe-magnus nucleus and locus coeruleus. Raphe-magnus nucleus neurons are serotonergic and locus coeruleus neurons secrete norepinephrine. So these two neurotransmitters will keep the cerebral cortex alert and awake. Okay? Iron lady, what happened? Repeating of sound का क्या मतलब हुआ? Echo हो रहा है क्या? Iron lady? Iron lady? Wow. बोलो. कहाँ हो Iron lady? I hope you're a lady. पता चला Iron lady is actually the Iron Man. What is repeating of sound? Echo हो रहा है क्या? Any problem with the audio, please, so that I can move forward? No echo. All right, great. Chalo. So let's see this. So what I was trying to tell you was, if you look at the cross section of the spinal cord, right? This is the gray matter. This is the gray matter here. Okay. Now this is now if you look at the gray matter, especially in the dorsal horn, it is divided into laminae. It is divided into laminae. Right? There's lamina 1, lamina 2, lamina 3, lamina 4, lamina 5, 6, 7, 8, 9. So these are divided into laminae. And I'm writing this in Roman numerals, lamina. So these are the laminae. Now, when you look at the C fibers will specifically synapse in lamina 2. They specifically synapse in lamina 2. And lamina 2 in the dorsal horn, this is known as substantia gelatinosa. Substantia gelatinosa of Rolando, right? Substantia gelatinosa of Rolando. This has been asked as a question. Substantia gelatinosa of Rolando, it corresponds with which lamina? It corresponds with lamina 2. And what is the significance of lamina 2? The C fibers specifically synapse in lamina 2, right? C fibers will synapse in lamina 2. C fibers synapse in lamina 2, right? And what is this lamina 2? Lamina 2 is also known as the substantia gelatinosa of Rolando. But if you look at the A delta fibers synapse in lamina 1 or lamina 5. Lamina 1 or even in lamina 5. Not in lamina 2. Lamina 2 is specifically meant for the C fibers. A delta fibers will synapse either in lamina 1 or in either lamina 1 or in lamina 5, right? So this is as far as your the slow pain fibers are concerned, slow pain and the fast pain fibers. So again, what are the differences between slow pain and the fast pain fibers? We've already discussed the synonyms for slow and fast pain. Yes, we also discussed it is carried by A delta fibers and slow pain by C fibers. This is felt within 0.1 second, felt after 1 second. The stimulus is mechanical or thermal, and here the stimulus is chemical. Neurotransmitter is glutamate, and here the neurotransmitter is substance P. There's a difference. The slow pain fibers give a number of collaterals and terminate in the thalamus. Fast pain fibers give no collaterals and terminate in the cortex. Right? And the another important difference, C fibers will synapse in lamina 2 of the dorsal horn, and A delta fibers synapse in lamina 1 or lamina 5. Lamina means a layer. Dorsal horn is divided into 5 layers. Gray matter is divided into 9, right? So it's 1, 2, 3, 4, 5, 6, 7, 8, 9, like that. But lamina 2 is specifically meant for C fibers. A delta fibers will synapse in lamina 1 or lamina 5. Lamina means a layer. These are the differences between slow and fast pain pathways. Is everybody okay with that? Lamina 1 or lamina 5, sorry. Lamina 1 or lamina 5. Okay? Lamina 1 or lamina 5. A delta fibers synapse in lamina 1 or 5. C fibers synapse in lamina 2, 5. Okay. Yes, this is lamina 5. Rexed laminas, absolutely correct. Now, next let's go on to what are the endogenous Kamina 1 or 5. Yeah, okay. Let's go on to what are the endogenous analgesia systems. Right? Let's see. AGM, substantia gelatinosa of Rolando. Now you have the endogenous. What are the endogenous analgesia systems? What are the endogenous analgesia systems? Now, what is endogenous analgesia systems? Endogenous analgesia systems means have mechanisms for controlling pain, right? We have within the body, there are mechanisms for controlling pain. Now, let us see what is the endogenous analgesia system. The first one is what is known as the gate control theory. First one is what is known as the gate control theory of Melzack. Gate control theory of Melzack and Wall, right? The gate control theory of Melzack and Wall. Now, this is a very common experience. See, whenever there is injury, whenever there is pain, what do? You lightly rub that area, and rubbing that area decreases the pain, isn't it? This is a very common thing, right? Anybody, especially in children, when they get hurt, you slightly rub that area, and that decreases the transmission of pain, right? Now, Now, if you look at this, when you lightly rub that area, you will stimulate the large diameter. You stimulate the large diameter myelinated touch fibers. You stimulate the large diameter myelinated touch fibers. And which are these large diameter myelinated touch fibers? This is A beta. You stimulate these large diameter myelinated touch fibers, and the central process now ascends upwards in the posterior column, right? And this is the C fiber which is carrying pain. This is the C fiber which synapses in the dorsal horn of the spinal cord, lamina 2. This is a C fiber which is meant for pain. Okay. It synapses here, and there is a second order sensory neuron which crosses over to the opposite side and ascends upwards. Okay. Now what happens is, now the A beta fiber, now this question has been asked so many times that in the gate control theory, which touch fiber is going to be excited? The touch fiber which is excited is A beta. It is a fast conducting fiber. It's a large diameter and myelinated. It is a fast conducting fiber. And this one, this A beta fiber gives a collateral. And when it gives a collateral, it synapses with a small inhibitory neuron. This is an encephalinergic neuron. Yes, this is an encephalinergic neuron, which is present in, this is an encephalinergic neuron. That means it releases enkephalin, and this encephalinergic neuron is present in the dorsal horn. And this encephalinergic neuron, which is present in the dorsal horn, this now causes a, if you can see an axonal synapse here, right? So this causes a presynaptic inhibition. This causes a presynaptic inhibition of the pain pathway. This causes presynaptic inhibition of the pain pathway. Right? There is a presynaptic inhibition of the pain pathway, which now decreases the transmission of pain. It decreases the pain transmission. Please remember, it cannot completely abolish the pain, but it will now decrease the transmission. It will decrease the pain transmission. There is a presynaptic inhibition of the pain pathway, and this in turn decreases the pain transmission. When you lightly rub that area, you will excite these A beta fibers, and these A beta fibers now send excitatory impulses to this encephalinergic neuron. This encephalinergic neuron forms an axonal synapse with the pain pathway, and axonal synapse, it's an inhibitory neuron. It secretes enkephalin on the axonal synapse, so it now causes a presynaptic inhibition of the pain pathway. And I did this with you a little earlier, and I told you presynaptic inhibition causes a decrease in the transmission. It cannot abolish the pain, but it definitely decreases the pain transmission. Okay? This is as far as your the gate control theory is concerned. Yes, so gate control theory, which touch fiber is excited? A beta. What sort of an inhibition is this? This is a presynaptic inhibition of the pain pathway. Neuron is involved. This is an encephalinergic neuron, which is present in the dorsal horn. Which lamina of the dorsal horn? This is present in lamina 2. This is present in the lamina 2 of the dorsal horn. Right? This is present in lamina 2. That is the substantia gelatinosa of the dorsal horn. Okay? Now, this is as far as your gate control theory is concerned. Now, there is also something known as TENS. And what is TENS? TENS is transcutaneous. This is a transcutaneous electrical nerve stimulation. Transcutaneous electrical nerve stimulation. Right? Transcutaneous electrical nerve stimulation. What is transcutaneous electrical nerve stimulation? This is done for intractable pain. A transcutaneous electrical nerve stimulation is done for intractable pain. And what is intractable pain? Intractable pain means pain which does not respond. Intractable pain means pain which does not respond to medical management. Pain which does not respond to medical management. Right? See, the first line of treatment of pain is always medical. We have excellent drugs to manage pain. But in certain types of pain, like for instance associated with certain types of cancers, right, which is not responding to medical management, you can do what is known as TENS, transcutaneous electrical nerve stimulation, right? Pain associated with cancers, right? With certain types of cancers, not responding to medical management of pain, you can do transcutaneous electrical nerve stimulation. Now, transcutaneous electrical nerve stimulation, this is based on the gate control theory. This is based on the gate control theory. Yes, pain associated with PIBD, absolutely right, which is not responding to medical management. Or, for instance, in certain cases, you cannot give too many opioids. Yes, because of fear of addiction. So it's better to go in for what happens in transcutaneous electrical nerve stimulation is you use an electrode, introduce it through the skin, and this will stimulate the A beta touch fibers for which are A beta, right? And that in turn causes a presynaptic inhibition of the pain pathway, right? See this again. In transcutaneous electrical nerve stimulation, you will stimulate the A beta fibers. What are these A beta fibers? These are large diameter myelinated touch fibers. And once these are excited, they will stimulate, they give a collateral to encephalinergic neuron. Where is the encephalinergic neuron located? Encephalinergic is located in lamina 2 of the dorsal horn, which causes a presynaptic inhibition of the pain pathway. Okay? Okay. A beta fiber के ऊपर मैंने question लिखा है सरगम वर्मा. It was asked as a question कि gate control theory में कौन सा touch fiber excite होता है, and that is A beta. ठीक है? Yes, Shashidhar, absolutely right. Polyarthropathy, which is not responding to medical management. You can do TENS, right? TENS is transcutaneous electrical nerve stimulation. Okay? All right. This is known as the gate control theory. Transcutaneous electrical nerve stimulation, this is based on the gate control theory. This was also asked as a question. This was a neat question which was asked. Yes, this is transcutaneous. Second mechanism for endogenous pain, right? Second mechanism for the endogenous analgesia system. This is known as the descending pain inhibiting pathway. Descending pain inhibiting pathway. Yes, there is an endogenous descending pain inhibiting pathway. Yes, Jaydeep does. It is a fiber for fine touch which goes into the posterior column. Okay? Yes, it provides a temporary pain relief unless the pathology itself is corrected, isn't it? So this will give you temporary pain relief. Yes, no side effects. Okay? Lamina 2 and substantia gelatinosa are the same. Acupuncture is not based on this. Acupuncture is a completely different thing, which is not related to this particular. There are certain points in the body which are excited. Probably could be based on this, but not really. We do not believe acupuncture to be a very scientific mechanism. Yes, all right. So descending pain inhibiting pathway. What is descending pain inhibiting pathway? Now, this descending pain inhibiting pathway, it starts from descending pain inhibiting pathway. It starts from the periaqueductal gray. Periaqueductal gray. And I just told you a little while back that the C fibers, which are the slow pain fibers, they give a collateral to the periaqueductal gray. They give a collateral to the periaqueductal gray neurons, right? They give a collateral to the periaqueductal gray neurons. Yes? Now, periaqueductal gray neurons, remember I told you what is periaqueductal gray? This is the gray matter around the aqueductive sylvius. Now, this periaqueductal gray neuron, this also receives excitatory impulses from the cortex. It also receives excitatory impulses from the limbic system. You know that emotions and pain perception also have a very close association, isn't it? Emotions and pain perception, isn't it? Now, you know that supposing when you are, let's say, when you are studying, dukhi ho, you are sad, studying and sad, small aches and pains become such a big issue. Yes, but when you are in a happier state of mind, small aches and pains are ignored, isn't it? Right? So emotions and your pain perception also has a very close association. A very common kind of an example which you must have heard is during a war, when a soldier is shot, there is a gunshot injury, at that time, he does not even feel the pain. because at that time his level of motivation, his emotions are the emotional state is so high that he does not feel the pain at that particular time. So that means cortex limbic system also can affect this descending pain inhibiting pathway. Right? So this descending pain inhibiting pathway, it starts from the periaqueductal gray, it moves down, receives collaterals from the C fibers, from the slow pain fibers, as also from the cortex and from the limbic system. Now these periaqueductal gray fibers, they project to the Raffi-Magnus nucleus. And I've already told you Raffi-Magnus nucleus neurons. Raffi-Magnus nucleus neurons, these are serotonergic. Now, some of these Raffi-Magnus nucleus neurons can project to the cortex, but some descend downwards. Yes? And these fibers which descend downwards, they will secrete serotonin here, right? They secrete serotonin. And these neurons will now excite the same encephalinergic neuron. This is the enkephalin secreting neuron in the dorsal horn. And this encephalinergic neuron now forms an axonal synapse with the C fiber for pain. It causes a presynaptic inhibition and in fact decreases the pain transmission. Have you understood? This is what is known as a descending pain inhibiting pathway. It starts from the periaqueductal gray. The neurons of the periaqueductal gray project to the Raffi-Magnus nucleus, which is serotonergic. Raffi-Magnus nucleus can go towards the cortex, which I've discussed with you earlier, keeps the cortex alert and awake, but some Raffi-Magnus nucleus neurons can descend downwards and reach the dorsal horn, where they stimulate the same encephalinergic neurons, which in turn causes a presynaptic inhibition of the pain pathway. Right? Presynaptic inhibition of the pain pathway. It causes a presynaptic inhibition of the pain pathway. Right? Presynaptic inhibition of the pain pathway. And it decreases the pain transmission, right? So these encephalinergic neurons, they cause a presynaptic inhibition of the pain pathway, which in turn decreases the pain transmission. Okay? The point which I'm trying to make over here is these encephalinergic neurons which are present in the dorsal horn, they can be stimulated by touch fibers, or they can be stimulated by this descending pain inhibiting pathway which comes from the periaqueductal gray. And have you noticed something? That the pain fibers themselves stimulate the periaqueductal gray, and periaqueductal gray will decrease the transmission of pain. Have you understood? So this is your, this is what is the endogenous analgesia systems. The first one was gate control theory. What is gate control theory? Here, the A beta fibers will stimulate the encephalinergic neurons, and which now closes the gate. What is the gate? It now decreases the transmission of pain through the pain pathway. So it is closing that gate. Yes, this is touch fibers. And no, this is not feed-forward mechanism. This is a presynaptic inhibition. Ajinkya, this is Nikita. It's neither feedback nor this is feed-forward. In front of you, I have written this is presynaptic inhibition of the pain pathway. Right? Presynaptic inhibition of the pain pathway. And the second is the descending pain inhibiting mechanism, which starts from the periaqueductal gray, stimulates the same encephalinergic neurons, which decreases the transmission of pain. Okay? How do I show you in one page? I can decrease it, there is no problem. Here, this is the gate control theory. You must understand, Karnan, the pain carried through A delta is transient, just for that moment, which causes you to withdraw. The pain that you feel is carried by C fibers. Have you understood? The fast pain is only responsible for flexor withdrawal, but the pain that you feel due to the tissue damage is carried by the C fibers. Okay? Ganesh, Which neurotransmitter is released by encephalinergic neuron? Enkephalin. Serotonergic neuron releases serotonin. Encephalinergic neuron releases enkephalin. Dopaminergic neuron releases dopamine. Okay? This is not negative feedback. This is a presynaptic transmission of the pain pathway. Okay. All right. Prolonged means, Ishita Mehra, you must understand it will vary, na? Depending upon the pathology. Isn't it? You have not corrected the pathology in TENS. You have only reduced the transmission. So it depends on the disease. It depends upon the pathology. It depends from person to person. So how can I say that TENS will last for this much time in a patient? Isn't it? All right. Okay, so this is your where way, Ishita Mehra? How prolonged is the effect of TENS? I've just explained it. Achha. So this is your endogenous analgesia systems. Now, 2-3 important points is when you look at when you look at what you understand by visceral pain, right? Visceral pain. Visceral pain, now what we've discussed up till now is the somatic pain that is arising from the soma, from the skin. This is visceral pain, which arises from the viscera. Now, when you look at visceral pain is very diffuse. It is very, very poorly localized, right? This is poorly localized. Ipsita Paul, beta, please understand, wherever you see an axoaxonal synapse, it is a presynaptic inhibition. It is not a feed-forward inhibition. Axoaxonal synapse is particularly seen in presynaptic inhibition, right? Particularly seen in presynaptic inhibition. Okay? Now, visceral pain this is poorly localized. This is poorly localized. Visceral pain is usually referred. This is usually referred. And visceral pain is carried by C fibers. This is carried by C fibers. Okay? This is it's poorly localized. It is usually referred and it is carried by C fibers. Now, when you look at what are the theories for Andrew Murray Xavier as well as Priya, please see this. See, what is the descending pain inhibiting pathway? The descending pain inhibiting pathway will excite the same encephalinergic neuron, and that encephalinergic neuron is causing a presynaptic inhibition of the pain pathway. Why do I call it presynaptic inhibition? Because there is an axoaxonal synapse. Right? Axoaxonal synapse. This is your descending analgesia, descending pain inhibiting pathway. Right? Now, Sakshi Potidar, the fast pain is only responsible for flexor withdrawal. Go and touch a hot tawa in the kitchen. You'll feel a sharp pain which makes you withdraw your hand. That was A delta. But the pain that you feel because your hand has got burnt is because of C. Right? A delta is only responsible for flexor withdrawal. So it is just for a few seconds. Is it all right? Just for that, maybe, like I said, it is felt, in fact, after 0.1 second. What you feel, or for example, when you're touching a rose, there is a thorn. The moment you touch that thorn, you prick your finger, there is a sharp pain, which makes you withdraw your hand. That was A delta. But the pain that you feel because there has been a tissue injury is because of C. Have you understood? That is the difference between fast and slow pain pathway. All right. Okay. Now, as far as what are the theories for referred pain? What are the theories for referred pain? Let's try and do that. Theories for referred pain. Why does the visceral pain get referred? Yes. Why does the visceral pain get referred? Right? Now, what are the theories for referred pain? The first theory for referred pain there is a common origin. There is a common origin. Why does the pain get referred to a particular area? A common origin. For example, like for instance, you know that cardiac pain is referred to the neck, isn't it? To right up to the jaw. This could be because it is the heart and the neck. What happens is, for example, cardiac pain is referred to the neck. Cardiac pain is referred to the angle of the jaw, referred to the neck, right? Right? The cardiac pain is referred to the neck, which is the angle of the jaw. The reason could be, possible reason is the heart develops in the neck. If you look at your embryology, heart develops in the neck and then migrates downwards to occupy a position in the mediastinum. It develops in the neck. If you look at the embryology part of it, right? If you remember your embryology, and that is embryology, the heart develops in the neck, then it descends into the mediastinum. So because there is a common origin, that is why probably cardiac pain is being conducted, it is being referred to the neck or the angle of the jaw, right? So this is one of the theories, that they have a common origin. So heart probably originates in the neck, that is why cardiac pain is felt in the angle of the jaw. Second reason could be, what are the theories? Please remember, these are just theories. Exact reason why there is a referred pain. This is the second is what is known as the convergence theory. Convergence theory. Shubhangi Agarwal, aap kya question pooch rahe ho beta? You are saying if you touch a hot object when you are sleeping, I don't know how you will do that. You will produce some tissue damage, na? Your hand will get burnt, na? It can't be only the fast pain and no tissue damage. There is also a convergence theory for referred pain. What is convergence theory? The convergence theory is that remember, you've got this is the second order sensory neuron. Yes. You've got from the skin, you have this was the first order sensory neuron which converges. This is right? This was the first order sensory neuron. It stimulates the second order sensory neuron. Yes. And this now moves upwards. This is your pain pathway. Yes, you give a painful stimulus over here, right? Painful stimulus. This is what happens. This is a painful stimulus which is given, right? And the impulses will go in this direction. Yes, towards the spinal cord and then to the cortex, towards the cortex. Now, there is from the viscera itself also. This is the viscera here. Now, from the viscera, the first order sensory neuron from the viscera will converge on the same second order sensory neuron. Yes. Like for instance, you know that this is from the viscera. Yes. So the sensory neurons from somatic structure, sensory neurons from a somatic structure and the viscera, somatic structure and viscera converge on the same second order sensory neuron, right? Sensory neurons from the somatic structure and the viscera converge on the same second order sensory neurons. So what happens is the visceral pain then seems to arise from the somatic structure. Have you understood? Because they're both converging on the same second order sensory neuron. Therefore, the visceral pain seems to be visceral pain referred to the somatic structure. For example, the intestinal pain, periumbilical, or that is what is or the diaphragmatic pain, tip of the shoulder. It could be convergence theory. We are not very sure about what is the exact reason for the referred pain. Common origin, like somebody else has also pointed out, common nerve root. Yes, absolutely right. Common nerve root because of common origin, because embryologically they originated in the same site. Yes, that is by the common nerve root. Yes, so basically, like I told you, the example of the heart. Heart develops in the neck and then moves downwards. Isn't it? So that is why this has got the common nerve roots. And convergence theory, where the first order sensory neuron from the somatic structure as well as from the viscera converge on the same second order sensory neurons. Now, this is as far as your the theories for referred pain is concerned. Next, let's go on to what do you understand by hyperalgesia? What is hyperalgesia? What is allodynia and what is hyperalgesia? What are the differences between allodynia and what is hyperalgesia? When we describe pain clinically like sharp shooting pain, wherever please remember the fast pain is only, you are basically sorobhermic, you are looking at visceral pain. When you say sharp shooting pain, or even if it's somatic pain, please remember the fast pain is responsible for the flexor withdrawal response. The pain that you feel is because of C fibers. Now you are going into sorobhermic. Character of the pain, clinical, isn't it? Two types of pain, fast and slow pain pathways. The pain that we feel, the character can be described. You are using this character to describe the pain. When you take a history, you look at the character of the pain. You're using those terms and you're bringing it here, isn't it? That is C fibers. The pain that you feel is because of C fiber. Now, the character described by the patient or you write in your notes will be different. Okay? All right. So do not get confused with that, right? And what is hyperalgesia? Now, what is allodynia and what is hyperalgesia? Now, allodynia is when a known painful stimulus produces pain. That is known as allodynia. For example, when you look at an osteoarthritic joint, in an osteoarthritic joint, a movement is actually a known painful stimulus. Movement is a non-noxious stimulus. Non-noxious stimulus. रक्षांदा, अगर आपको खत्म करना है तो आप जाइए ना, आप बाकियों को क्यों डिस्टर्ब कर रहे हैं? आपके लिए खत्म है, आप बंद करके चले जाइए, है ना? But let's be a little. Movement is a non-noxious stimulus which produces pain. मुझे क्या है, पेन अभी खत्म कर देते हैं. प्रॉब्लम क्या है? CNS मर्जी खत्म करने के लिए बोलिए, तभी कर देंगे. So what is allodynia? Allodynia is when a non-painful stimulus produces pain. Yes, for example, in an osteoarthritic joint, when a non-noxious, non-painful stimulus produces pain, we call it allodynia. What is hyperalgesia? Hyperalgesia is a heightened pain perception. Heightened pain perception. Yes, heightened pain perception. That is hyperalgesia. Heightened pain perception is heightened pain perception. There are two types of hyperalgesia. You've got a primary hyperalgesia and you've got a secondary hyperalgesia. Primary and secondary hyperalgesia. Now, what is primary hyperalgesia? Primary hyperalgesia, this is over area tissue damage. This is over areas of tissue damage. Right? This is over area damage. Now, what happens in a primary hyperalgesia? And this is again a very common experience, that if there is an injury somewhere, yes, there is a tissue damage somewhere, another painful stimulus over that same area, and the pain that you feel is much more than normal. isn't it? That is called a primary hyperalgesia. This is over areas of tissue damage. Wherever there is a tissue damage, wherever there is an injury, कहीं पर चोट लगा है, दोबारा वहां चोट लगता है, तो बहुत ज्यादा दर्द महसूस होता है. That is called primary hyperalgesia. So this is over areas of tissue damage. Now, what happens over here is, here algogenic substances. Algogenic substances. What are algogenic substances? Algogenic substances are pain-producing substances. Wherever there is injury, wherever there is inflammation, there are algogenic substances, pain-producing chemicals which are released. Which are these pain-producing chemicals? Bradykinin, histamine. These are released. These are released wherever there is injury, wherever there is inflammation. And algogenic substances, they lower the pain threshold. They lower the pain threshold. So a small painful stimulus and the pain that you feel is much more than normal. So this is what is known as primary hyperalgesia. This is over areas of tissue damage. And algogenic substances will lower the pain threshold. Okay? Now, what happens in secondary hyperalgesia? Secondary hyperalgesia. Now, secondary hyperalgesia, this is over normal skin. Okay? This is over normal skin. So, a repetitive painful stimulation. Repeatedly, if you give a painful stimulation over the same area, repeated painful stimuli, isn't it? Matlab, if you remember your childhood days, repeated slaps over the same area. Yes, ek ke baad ek jab thappad pada ek hi jagah. Repetitive painful stimulation over the same area, it produces what is known as a hypersensitization. There is a hypersensitization, and that in turn increases the pain perception. Right? This increases the pain perception. This is what is secondary hyperalgesia. This is over a normal skin. Repetitive painful stimuli over the same area over normal skin will produce what is known as a hypersensitization, sort of a temporal summation. Right? The stimuli are getting summated, so it causes hypersensitization, which in turn increases the pain perception. Okay? And this again has been asked as a question. What is the physiological basis of secondary hyperalgesia? This is repetitive painful stimuli producing a hypersensitization. Primary hyperalgesia over areas of tissue damage, where algogenic substances will lower the pain threshold. Yes. What is allodynia? Allodynia is non-noxious stimulus or a non-painful stimulus. Producing pain is known as allodynia. Hyperalgesia is heightened pain perception, primary as well as secondary hyperalgesia. Right? Histamine is an inflammatory chemical, isn't it? Whenever there is inflammation, there is release of bradykinin, there is release of histamine, and they can these are acting as algogenic substances. Algogenic substances. Trigeminal neuralgia is a neuropathic pain. And again can be described as allodynia. Okay. Algogenic substances are pain-producing substances. What are algogenic substances? These are pain-producing substances. Mohan Raj, there is no adaptation. Pain receptors do not adapt. I've done that with you. So there is no question of adaptation. Mohan Raj. Okay? Algogenic substances are pain-producing substances. They decrease the pain threshold. Remember, the threshold potential to generate an action potential is -55, but these lower the pain threshold so that a smaller stimulus produces more pain. It causes a Ghyasodine tolerance नहीं होगा बेटा, adaptation नहीं होगा. मैंने आपको शुरू में ही बताया कि pain receptors do not adapt. ठीक है? Pain receptors do not adapt. Yes, that Nikita, the same thing, they do not adapt. All right. Okay. So this is as far as your hyperalgesia, allodynia and hyperalgesia is concerned. Now, this completes your topic of pain, thankfully. Let's go on to the next thing. Next, which I'm going to discuss with you is the thalamus. Right? Thalamus. Let's see thalamus. Let's discuss the thalamus in a little bit of detail. Now, what is thalamus? Thalamus is this is also described as the grand sensory relay nucleus. This is also described as the grand sensory relay nucleus. All sensations relay in the thalamus. We've already discussed that the sensory relay nucleus in the thalamus is ventroposterolateral, right? So this is the grand sensory relay nucleus. So when you look at the relay nuclei, if you look at the relay nuclei in the thalamus, these can be described as these relay nuclei in the thalamus. They can be described as there are two types of relay nuclei, and the two types of relay nuclei are non-specific and specific. The relay nuclei are non-specific and specific, right? Non-specific and specific. Which are the non-specific thalamic relay nuclei? These are midline, and intralaminar. Midline and intralaminar. Okay? Midline and intralaminar. ठीक है? मीमांसा threshold का meaning सब जगह same होता है. ये क्या मतलब हुआ? What do you mean by that? Threshold. There can be lowering of the pain threshold. For example, now there is, because of all these inane comments, my threshold for becoming irritable has reduced, isn't it? So similarly, alcoholic substances reduce the threshold for pain. Yes, so that a small painful stimulus is able to generate more impulses. Have you understood? So that is what is known as lowering the threshold. Yes, this is the thalamic nuclei can be. Oh, okay, TK. If you're explaining each other, then it's fine. There's no genuine doubt. All right. Okay, so let me concentrate on what I was trying to tell you. Non-specific is midline and intralaminar. Specific is, what is specific? Specific is for somatic sensations. Somatic sensations. For somatic sensations, a specific thalamic nucleus is ventero-posterolateral nucleus. For somatic sensations is ventero-posterolateral nucleus. Then number two, for the visual pathway. For the visual pathway, the nucleus which is important here for the visual pathway is LGB, lateral geniculate body. For the visual pathway is lateral geniculate body. For the auditory pathway, is a medial geniculate body. For auditory pathway is medial geniculate body. For taste, this is a neat question which was asked in 2018. For taste, which is the thalamic relay nucleus, this is ventroposteromedial. Ventroposteromedial. For olfaction, this is mediodorsal thalamic. For olfaction is mediodorsal thalamic, right? And mediodorsal thalamic is also known as dorsomedial, right? Dorsomedial. Olfaction is mediodorsal thalamic, also known as dorsomedial. Right? So these are your specific thalamic relay nuclei. For somatic sensations, both in the posterior column as well as in the spinothalamic tract, this is ventroposterolateral. For visual pathway, LGP. For auditory pathway, MGB, easy way to remember. L for light, so visual pathway, lateral geniculate body. M for music, so for auditory pathway, medial geniculate body. Okay? For taste, ventroposteromedial. For olfaction, mediodorsal thalamic, which is also known as dorsomedial. Right? Now, please remember, for earlier knowledge, earlier it was believed that olfaction, earlier we believed that olfaction does not relay in the thalamus. But today we know that does not relay in the thalamus. Right? But today we know that there is a relay nucleus for olfaction, and that is known as mediodorsal thalamic, or MDT, which is also known as dorsomedial. For taste, ventroposteromedial. LGB is lateral geniculate body. MGB is medial geniculate body. VPL is ventroposterolateral. Right? Ventroposterolateral. So earlier we thought olfaction does not relay in the thalamus. So older knowledge, older questions, olfaction does not relay in the thalamus. Right? The relay nucleus for olfaction is, now we know it is mediodorsal thalamic or dorsomedial. Again, this was a question which was asked. Right? This was the thalamic, these are the sensory relay nuclei in the thalamus. Now, remember, thalamus is also a very important part of what is known as the Papez circuit. Thalamus is a very important part of the Papez circuit. Now, what is this Papez circuit? Papez circuit is involved in, this is conversion of short-term to long-term memory. This is involved in learning. This is also involved in emotions, right? Papez circuit, this is involved in memory, in learning, and emotions. Thalamus forms a very important part of the Papez circuit. Right? This has an important role to play in memory, conversion of short-term to long-term memory, as well as learning, as well as, like I said, the and in emotions. Yes, and in emotions. Now, the Papez circuit. Now, this starts from the hippocampus. Yes, this starts from the hippocampus. From the hippocampus, yes, hippocampus, please remember, is involved in the conversion of short-term to long-term memory. This is such an important part which is involved in the conversion of short-term to long-term memory. This is the hippocampus. From the hippocampus, the impulses now go to the mammillary bodies of hypothalamus. Yes, from the mammillary bodies of hypothalamus, impulses will go into the mammillary bodies of hypothalamus. Hippocampus to mammillary. I'm describing the Papez circuit for you, which is involved in conversion of short-term to long-term memory. So from hippocampus to mammillary bodies of hypothalamus. From mammillary bodies of hypothalamus to the anterior thalamic nuclei. Right, to the anterior thalamic nuclei. Remember, I just told you that the thalamus is a very important part of the Papez circuit. Which nucleus of the thalamus is important part of the Papez circuit? This is the anterior thalamic nuclei. And this tract which arises from the mammillary bodies to the anterior thalamic nuclei, this is known as the mammillothalamic tract. Thalamic tract, or this is also known as the tract of. This is also known as the tract of Wick and Az. Tract of Wick and Az. Hippocampus to mammillary bodies to anterior thalamic nuclei, Anterior thalamic nuclei, from here they can also go to the anterior thalamic nuclei to the prefrontal cortex, to the basal forebrain, and back to the hippocampus. So this becomes a circuit, right? Basal forebrain and back to the hippocampus. Yes. This is, like I said, a circuit which is involved in the conversion of short-term to long-term memory. And in the basal forebrain, you have the nucleus basalis. Nucleus basalis of Maynard. Nucleus basalis of Maynard. Right? Nucleus basalis of Maynard. This is affected in Alzheimer's. Right? To convert any short-term memory to long-term memory, this circuit must be repeatedly excited. We keep telling you, please revise, because what do we want you to do? We want you to repeatedly excite the circuit, right? So once the circuit is repeatedly excited, then the memory is stored in the neocortex as a sequence of synapses. Storage will be as a sequence of synapses. The sequence will be in the neocortex as the storage will be in this neocortex as a sequence of synapses. Right? From the basal forebrain, connections are also with the amygdala. What is amygdala? Amygdala is the window of the limbic system. It is a part of the limbic system. It is concerned with emotions. So memories with a high emotional content. Memories with a high emotional content. Memories with a high emotional content will go into the amygdala. This is the window of the limbic system. It is a part of the limbic system, right? And it will go into the amygdala. Yes. This is as far as your the Papez circuit is concerned. One small connection which is also present is from the anterior thalamic nuclei. Impulses can also go into the limbic cortex via the cingulate gyrus. Cingulate gyrus, which in turn now goes into the parahippocampal gyrus. And the entorhinal cortex. Parahippocampal gyrus as well as to the entorhinal cortex. See, basically what is this trying to tell you? Emotions and memories are also very closely related, isn't it? Emotions and memories are also very closely related. Yes, something which makes you happy or it makes you sad, you tend to remember that much more, right? So it will have connections with the limbic system as well. From the anterior thalamic nuclei, you can have impulses which straight away go via the cingulate gyrus to the parahippocampal gyrus as well as the entorhinal cortex. Or you can also have fibers which go to the prefrontal cortex, the basal forebrain, back to the hippocampus, so that this becomes a like I said, a circuit which is involved in memory, right? So this is as far as your let's see this once again. Let's see this once again. When you look at the hippo, what is this Papez circuit? The main circuit which is involved in conversion of short-term to long-term memory from hippocampus to the mammillary bodies to the anterior thalamic nucleus, prefrontal cortex, basal forebrain, back to the hippocampus. Okay? When this circuit is repeatedly excited, right, conversion of short-term to long-term memory, then the memory will be stored in the neocortex as a sequence of synapses. Fibers connections are also between the basal forebrain and the amygdala. So memories with a high emotional content will go into the amygdala. From the anterior thalamic nucleus, there are also connections directly with the limbic system, that is via the cingulate gyrus and the parahippocampal gyrus and entorhinal cortex. This is for the emotions. I remember I told Pape's circuit is involved in conversion of short-term to long-term memory, as well as for learning and emotions. All right, so this is as far as your window of the limbic system is literally, if you want to know what is inside a house, you peep through the window. So when you look at what is the emotional makeup of a person, what is this is the window. Window is the amygdala. So everything which has got a high emotional content will pass through the amygdala. Okay? The tract is tract of Wick and AZ. VICQ, Wick and AZ. This is the mammillothalamic tract. All right. This is your Pape's circuit. Now, this question has been asked a number of times. Which part is concerned with conversion of short-term to long-term memory? Answer is hippocampus. What is the window of the limbic system? Window of the limbic system is the amygdala. Where does the storage take place? Storage is in the neocortex. The storage will be as a sequence of synapses. Okay? Chronombomic cingulate gyrus is a part of the limbic system. So emotions, entorhinal cortex, parahippocampal gyrus, cingulate gyrus, these are all parts of the limbic system. Remember, I told you this has a role to play even in emotions. Have you understood? So this is one connection, which is these are parts of the limbic system. So for anterior thalamic nucleus, this can also go to the limbic system. The emotions, the emotions will stimulate the limbic system. Have you understood? Okay. All right. So this is as far as the thalamus is concerned. Next, let's go on to let's have a look at what are the different types of reflexes. Let's see the next thing, and that is what are the different types of reflexes. Reflexes, yes? Now, based on the number of synapses, you have a asynaptic reflex, a monosynaptic reflex. Reflex is an automatic response to a stimulus. Yes, automatic response to a stimulus, that is known as a reflex. The automatic response to a stimulus is known as a reflex. Automatic response to a stimulus. Now, based on the number of synapses, reflexes can be, based on the number of synapses, reflexes can be divided into. Reflexes can be asynaptic. What is the example of an asynaptic reflex? Asynaptic reflex is what is known as the axon reflex. Asynaptic is the axon reflex. It could be monosynaptic. Monosynaptic is what is known as the stretch reflex. Stretch reflex. Bisynaptic is what is known as the inverse stretch reflex. Inverse stretch reflex. Yes, and you have polysynaptic. Polysynaptic is most reflexes are polysynaptic. Majority of the reflexes are polysynaptic. So reflexes can be asynaptic, monosynaptic, bisynaptic, and polysynaptic. What is a reflex response? Reflex is an automatic response to the stimulus. Based on the number of synapses, you can have asynaptic, monosynaptic, bisynaptic, and polysynaptic. Examples of an asynaptic reflex: asynaptic means no synapse. This is an axon reflex. Monosynaptic means there is one synapse, which is the stretch reflex. Bisynaptic, it has got two synapses, which is known as the inverse stretch reflex. Inverse stretch reflex. And polysynaptic, most reflexes are going to be polysynaptic. Now, first let's look at what is the asynaptic reflex. Asynaptic reflex. Now, as far as the asynaptic reflex is concerned, the asynaptic reflex is, like I said, the axon reflex. Now, if you remember, whenever there is a blunt injury on the skin, or injury on the skin with a blunt instrument, yes, with a blunt object, yes, blunt injury on the skin, it gives rise to what is known as the triple response. Blunt injury on the skin gives rise to what is known as a triple response. Yes, triple response. Triple response. And what is a triple response? It has three. There is a red reaction. There is what is known as a flare. And number three is what is known as a wheel response. Right? Red reaction, flare, and wheel. Right? Red reaction, flare, and wheel. Now, what is this? This is what is blunt injury. For example, if you scratch the skin, on forearm with, let's say, a blunt instrument, forearm with a blunt object, yes, you will get this triple response. Yes, you will get a triple response. And the triple response has got three components. What are the three components? There is a red reaction, there is a flare, and there is a wheel. Now, it is this flare response which is because of the axon reflex. There is first a redness which is seen. Flare is a spreading redness. And number three is wheel. Wheel is dilatation over the it's a slight swelling which is seen over the area. Very common experience. You can take the forearm, you can scratch yourself with, let's say, a key or something, not with a knife, but not with a sharp instrument, but with a blunt object. For example, a key or something, and you will see these three responses. There is red reaction, there is flare, and there is wheel. Yes, and flare is because of the axon reflex. Axon reflex is responsible for the flare response. It's a neurological response. It's an asynaptic reflex. Now, how does flare happen? Let's try and see that. Yes, let's see how does flare happen. Now, supposing, like I said, when you give a stimulus on the skin, you are exciting the C fibers. Yes, there is a stimulus which is given over here. There is conduction of impulses via the C fibers into the spinal cord. Right? This is known as orthodromic conduction. This is the orthodromic conduction. Okay? Orthodromic conduction. What is orthodromic conduction? Here the impulses are moving from the periphery towards the spinal cord. This is known as orthodromic conduction of impulses. Yes. What is the neurotransmitter? Like I said, this is the C fiber. Yes. Neurotransmitter which is released over here is substance P. What is the neurotransmitter released in the spinal cord is substance P. Right? Now, these C fibers, there's a very unique arrangement here. These C fibers receive branches also from the blood vessels supplying the area, right? They also receive fibers from the blood vessels supplying the area, right? Now, substance P and CGRP, these are neurotransmitters. Substance P, large molecule slowly acting neurotransmitter. CGRP, calcitonin gene-related peptide. This is also a neurotransmitter. Large molecule slowly acting neurotransmitters. These are present throughout the axon. They are present throughout the nerve fiber. Yes, they are present throughout the axon. Now what happens is, now there are some impulses which will travel in this direction. This is known as an antidromic conduction. There is now an antidromic conduction, reverse direction, ulta direction, antidromic conduction. There is an antidromic conduction of impulses to the blood vessels supplying the area. There is an antidromic conduction of impulses to the blood vessels supplying the area. Right? Blood vessels supplying the area. And which is a neurotransmitter which is going to be secreted, because remember I told you the substance P and CGRP are present all over the axon. So there is now to the blood vessels supplying the area, so there is going to be release of substance P, release of substance P and CGRP, calcitonin gene-related peptide. This is also a neurotransmitter. Calcitonin gene-related peptide. This is also a, this in turn peptide, and this in turn causes a spreading redness. This causes a spreading redness, and that spreading redness is what is known as a flare response. Spreading redness is known as a flare response. What is this flare response due to? This is due to antidromic conduction of impulses. Antidromic conduction of impulses to the blood vessels supplying the area. There is release of neurotransmitter substance P and CGRP, which in turn causes a spreading redness, which is known as the flare response. Harshita, A delta fibers do not release substance P. Right? A delta fibers, substance P is primarily released by C fibers, and again, A delta are primarily meant for fast pain, for the flexor withdrawal response. Okay? So this is your antidromic conduction of impulses to the blood vessels supplying the area, which is responsible for the flare response. Let us look at the triple response once again. What is triple response due to? Triple response is due to triple response consists of three reactions. There is a red reaction, there is a flare, there is a wheel. A scratch by a blunt object will cause what is known as the triple response. Yes, like I said, if you take a key, chabi, right, and if that's a blunt instrument, scratch the forearm, you'll be able to see all the three reactions. Yes, or if you have long nails, if you scratch someone, you'll be able to see the triple reaction. A triple response, red reaction, flare, and wheel. What is a flare due to? Flare is due to an antidromic conduction of impulses to the blood vessels supplying the area, which causes release of substance P and CGRP, and this is known as spreading redness or a flare. Right? Red reaction will be at the site of injury. Flare is spreading redness. So the surrounding areas also become red. Okay? Surrounding areas will also become red. That is the difference between and flare. Manam abhigna. Okay, so this is your red reaction only at the site of injury, and this is a spreading redness. And there is a swelling which happens that is known as wheel. Okay. The antidromic, Anirudh Soni, antidromic is getting activated because of this unique connection which is present. The nerve fiber, this is receiving fibers also from the blood vessels. So if there are fibers which are present, remember a nerve fiber can conduct in both directions. So there is not only a orthodromic, there is also an antidromic towards the blood vessels. And again, the nerve fiber the substance P is present all over the nerve fiber. So substance P is released not only at the level of the spinal cord, it is also released at the level of the blood vessels, which is responsible for a flare response. No, antidromic, Subrajyoti Day, antidromic means opposite direction. Ortho means towards the spinal cord. Okay? Okay. So this is what is known as your flare response. right? Antibromic, opposite direction. Broma is conduction. Anti means opposite. Ortho means orthodromic, towards the spinal cord. Orthodromic, towards the spinal cord. Antibromic, ortho is straight towards the spinal cord. Anti is opposite direction. Okay. All right. Because if you use a sharp Divya Krishna, if you use a sharp object like a knife or a blade, you will prove a laceration. Then there is a point of seeing a triple reaction. Okay? All right. Gene-related peptide. Gene-related peptide. Okay. Now, the second one is stretch reflex and inverse stretch reflex. Let's see stretch reflex and inverse stretch reflex. Let's try and compare the two. Stretch reflex. First, let's see a comparison. Then I'll discuss the pathways of these two reflexes with you. And we'll discuss the stretch reflex and the inverse stretch reflex. Tara, if you're going to think about mugging it up, rote learning, that is not going to get you anywhere. The best way to remember something is to understand it. And the best way to remember something is to discuss it with someone, teach someone, isn't it? You get along with your close friends, you decide, you sort of discuss it with each other, teach each other. That's the best way to learn. Rote learning, learning by mugging up is not going to get you anywhere. The trend in questions is not, the kind of questions that you're getting are not based on rote learning, but on concepts, understanding the concepts. Okay? All right. Now, this is stretch reflex and inverse stretch reflex. So let's see the differences between the two. Now, stretch reflex, this is also known as, stretch reflex is also known as the deep tendon jerks. These are also known as the myotactic reflex. Stretch reflex is also known as the deep tendon jerk, or also known as the myotactic reflex. Deep tendon jerk or the myotactic reflex. Yes, stretch reflex, deep tendon jerks, or myotactic reflex. Now let's see stretch reflex. Stretch reflex, what is the stimulus for the stretch reflex? Stimulus for the stretch reflex is increase in muscle length. Increase in muscle length. Stimulus for the stretch reflex is increase in muscle length or stretch. Inverse stretch reflex, it is going to be increase in muscle tension. Increase in muscle tension. Yes, stretch reflex, deep tendon jerk, or the myotactic reflex. Stimulus here is increase in muscle length or stretch. Inverse stretch reflex is increase in muscle tension. What is the receptor for the stretch reflex? Receptor for the stretch reflex is the muscle spindle, and for the inverse stretch reflex is the Golgi tendon organ. Remember, what is the receptor for muscle length? Muscle spindle. What is the receptor for muscle tension? Golgi tendon organ. The afferent or the sensory fibers. Afferent or the sensory fibers from the muscle spindle we have already discussed. This is 1A and 2. From the Golgi tendon organ is 1B. Afferent or the sensory fibers from the muscle spindle 1A and 2. From the Golgi tendon organ is 1B. What is the center for the stretch reflex? Center for the stretch reflex is the spinal cord. For the inverse stretch reflex is also the spinal cord. Also the spinal cord. They are both spinal reflexes. Efferent or the motor. Efferent or motor of the stretch reflex is A alpha. for inverse stretch reflex is also A alpha. Remember, a reflex arc has a receptor, a sensory arm, a center, a efferent, and an effector, right? What is going to be the response? The response of the stretch reflex is a muscle contraction. Response of the stretch reflex is a muscle contraction. Inverse stretch reflex is a muscle relaxation. Response is a muscle contraction, and this is a muscle relaxation. Number of synapses. What are the number of synapses? For the stretch reflex, it is 1. Here it is 2. Stretch reflex is a monosynaptic reflex. Inverse stretch reflex is a bisynaptic reflex. Right? Bisynaptic reflex. So this is as far as your differences between the stretch reflex and the inverse stretch reflex is concerned. I'll try and put them in one page and let's see if you can follow that. Stimulus for the stretch reflex, increase in muscle length. Here it is an increase in muscle tension. The receptor for the stretch reflex is the muscle spindle for the Golgi tendon organ. For the inverse stretch reflex, the receptor is the Golgi tendon organ. Afferent or the sensory fibers of the stretch reflex is 1A and 2. From the Golgi tendon organ is 1B. They enter into the spinal cord. Now they affect the A alpha motor neuron. The response of the stretch reflex is a muscle contraction. For the inverse stretch reflex is a muscle relaxation. Number of synapses is 1 for the stretch reflex and 2 bisynaptic reflex is the inverse stretch reflex. Now let's see this over here. Let's see this here, and that is, let's see the pathway of the stretch reflex. A common deep tendon jerk that you do is the knee jerk. Let's see, let's take the example of the knee jerk. Yes, knee jerk. Right? Knee jerk. This is an example of the stretch reflex, isn't it? When you take a knee hammer and tap on the patellar tendon, on the quadriceps tendon, there is a contraction of the quadriceps muscle and the leg moves forward. So let's try and see this. Let's try and see what is the pathway of the knee jerk. Yes. Now here is your subject. This is the quadriceps muscle. This is the quadriceps muscle. This is in the quadriceps tendon is inserted into the tibial tuberosity. So when I take my knee hammer and I tap on the tendon, the tendon gets indented like this. The tendon goes like this. Yes, the tendon, when I tap on the tendon, it goes like that. It indents. And remember, the tendon is continuous with the muscle. So there is now going to be an increase in the muscle length. There is an increase in the muscle length. Why? Because when I tap on the tendon gets indented and this stretches the muscle and there is an increase in the muscle length. Now, what is present within the muscle are these receptors, and these receptors are muscle spindle. Muscle spindles are receptors which are present inside the muscle. Muscle spindles are receptors for muscle length. When the muscle gets stretched, the muscle spindle will also get stretched. The sensory fibers from the muscle spindle, which I have already discussed with you, is 1A and 2, annulospiral and the flower spray ending. Annulospiral and the flower spray ending. And these enter into the spinal cord and they synapse with the A alpha motor neurons. They synapse with A alpha motor neurons. They excite the A alpha motor neurons, and these A alpha motor neurons will go towards the quadriceps muscle and they will a contraction of the quadriceps muscle. If the A alpha, we've already discussed, A alpha goes to the extrafusal muscle fibers and it stimulates these extrafusal muscle fibers, which are responsible for muscle contraction. There is a contraction of the quadriceps, and once there is a contraction of the quadriceps, the leg moves forward. And this is exactly what happens in the knee jerk. The leg moves forward. Right? So let's see this. The Pratiksha, Nathani, Rahul, Sanjay Singh Parmar, yes, the motor to muscle spindle is A gamma, but this is a reflex pathway which involves A alpha. Have you understood? Motor to muscle spindle is A gamma, motor of the reflex pathway of the stretch reflex is A alpha. Have you understood that? There is a difference. There is a difference between the two things. Have you understood? Oral A gamma nahi hai beta. It is A alpha. A gamma is motor to muscle spindle. This is A alpha, which is motor to the muscle, extrafusal muscle fibers. A gamma का significance क्या था? A gamma की activity जब बढ़ती है तो spindle stimulate होता है. I will discuss it with detail. Please have patience. Let me complete this, right? Listen to this. These are important concepts. You will be able to understand your medicine very well once you pay attention to this. If you're not going to pay attention, then of course it's your... all right. So this is the reflex arc which I'm describing. This is the stretch reflex, isn't it? Whenever you tap on the tendon, there is an increase in the muscle length. The muscle spindle is excited. The sensory fibers are 1A and 2, which carry impulses towards the spinal cord. The center is the spinal cord, and these sensory fibers directly synapse with the A alpha motor neurons, which goes towards the extrafusal muscle fibers. A alpha motor neurons will cause a muscle contraction, and the leg moves forward. So this is what is the pathway of the stretch reflex. Okay? Stretch reflex. So you must understand there are two important things here. Stimulation of the muscle spindle. Stimulation of the muscle spindle. Whenever the muscle spindle is excited, the response will be a muscle contraction. Right? Muscle contraction. And the reason is the stretch reflex. Yes, whenever the muscle spindle is excited, the stretch reflex will be excited, and the response is going to be a muscle contraction. Now, how can I stimulate the spindle? Now, go back to what we did when we did the muscle spindle. I discussed there are two ways to stimulate a muscle spindle. Number one, if I increase the muscle length, that is stretch. If I increase the muscle length, right? If I increase the muscle length, for example, stretch of the muscle, right? Or if I increase the A gamma motor neuron discharge. This I have discussed with you already. A gamma supplies the ends of the muscle spindle. If the A gamma is stimulated, the ends of the muscle spindle will contract, and if the ends contract, the central receptor portion gets stretched. And whenever the central receptor portion gets stretched, that is, the muscle spindle has got stimulated, and that results in a muscle contraction. So muscle spindle can be stimulated in two ways. Number one, if I increase the muscle length or stretch the muscle. And number two, if I increase the A gamma motor neuron discharge. If I increase the A gamma motor neuron discharge. So, and remember, whenever the spindle is excited, the result will be a muscle contraction, right? Result will be a muscle contraction. Okay? Now, an important part, and that is, yes, when I increase the A gamma discharge, yes, the spindle gets stimulated. Yes, there is going to be a muscle contraction, but very important point to understand. Listen to this very carefully. Now, SR is stretch reflex. That is what we are doing. Okay. Now, A gamma motor neurons Now, A gamma motor neurons, listen to this very carefully. A gamma motor neurons, these are not strong enough. These are not strong enough, and these are not plentiful enough. These are not strong enough, not plentiful enough to produce a motor movement. They do produce a muscle contraction, but not sufficient to produce a movement. Right? See, in a stretch reflex, the leg moves forward. Okay? But A gamma discharge, yes, it is stimulating the spindle. Yes, it is producing a muscle contraction, but not sufficient to produce a movement. But it increases muscle tone. It increases muscle tone. What is muscle tone? Muscle tone is described as, muscle tone is the state of partial contraction. It is the state of partial contraction of the muscle at rest. State of partial contraction of the muscle at rest. That is what is known as muscle tone. Have you understood? For example, if the elbow is extended, biceps is at rest. And if you feel for the biceps, there is some degree of tone. There is a degree of partial contraction of the biceps even at rest. That is called muscle tone. The biceps in this situation is not flabby. There is some degree of muscle contraction which is known as muscle tone. Yes. So please remember, A gamma discharge, yes, it stimulates the spindle. Yes, it produces a contraction, but not sufficient to produce a movement. It can only increase the muscle tone. Right? And what is muscle tone? Muscle tone is the state of partial contraction of the muscle at rest. Is that clear? So A alpha, contraction of extrafusal muscle fibers responsible for movement. A gamma will stimulate the spindle, produce a muscle contraction, but not sufficient to produce a movement. It can only increase the muscle tone. Got it. Yes. Hey, tonic seizure type. Seizure क्या है? बिल्कुल अलग चीज है. ये तो muscle tone तो normal है. तुम में भी है, मुझ में भी है. अगर muscle tone चली गई, that means end of story. Oh, ठीक है. All right. मृणाल जोशी, अगर लिम्बी नहीं है तो कहां पे रिफ्लेक्स देखोगे? अगर उसकी एम्पुटेशन लिम्बी, इफ देयर इज नो लिम्ब देन हाउ विल वी सी द रिफ्लेक्स? क्यों बेटा, क्यों ला रहे हो बीच में? सिंपल चीज को कॉम्प्लिकेट क्यों कर रहे हैं? Alright, A gamma is act. What is it, Shruti Madan? A gamma activated, muscle spindle intrafusal stretched. 1-2 afferents. A alpha extrafusal muscle contraction. Correct, absolutely correct. But the contraction is not sufficient to produce a movement. It is only sufficient to increase the muscle tone. ठीक है बेटा? A gamma वाला समझ आ गया? Shruti या whoever, sorry, who asked me just now, जिसने पूरा लिखा था. ठीक है? Okay. So this is as far as your okay. ठीक है? This is as far as your the stretch reflex is concerned. ठीक है? Stretch reflex, please remember, will stimulate the spindle, muscle contraction. A gamma will also stimulate the spindle, but only sufficient to increase the muscle tone, not to produce a movement. ठीक है? All right. Okay. Now, another important point is Prashant, which you have just brought it up. Let me just tell you this. Now, please remember, during a stretch reflex, one small point, during a stretch, SR is stretch reflex. During a stretch reflex, the dynamic response, absolutely right, MB psychotic muscle tone, yes. All right. Dynamic response is more than the static response. During a stretch reflex, this is an important point which has been asked as an AIMS question. During a stretch reflex, dynamic response is more than the static response. right? And what was the dynamic response? Dynamic response was in nuclear bag dynamic. What is the static response? Static response is in nuclear bag static and the nuclear bag static and the nuclear chain. All are going to be excited during the stretch reflex. Nuclear bag dynamic, nuclear bag static, nuclear chain, all are going to be excited, but the response is primarily in the nuclear bag dynamic, right? The nuclear dynamic response is much more than the static response. Okay? Acha, bas, lado nahi, no fighting. Okay? Okay. All right. Let's see the inverse stretch reflex. Let's see the inverse stretch reflex. Now, in inverse stretch reflex, if you remember, we said it's a bisynaptic reflex. The receptor is the Golgi tendon organ. Sensory fiber 1B center is the spinal cord. The efferent of this reflex is A alpha. It is a muscle relaxation and bisynaptic reflex. Okay? Now let us see what is the pathway of the inverse stretch reflex. So I'm doing the inverse stretch reflex. Seher Fatma, what stimulates the A gamma? I'll just do that with you. Don't worry, we will come to it. Okay? Abhi tak itna sach hai. Okay? Now let's see the inverse stretch reflex. What is the pathway of the inverse stretch reflex? Now, inverse stretch reflex. Now, what happens here is, whenever there is an increase in muscle tension, yes, whenever there is an increase in muscle tension, yes, and for example, when does the muscle tension increase? For example, lifting, while you are lifting a very heavy, very heavy weight. So many times it happens that you're trying to lift a very heavy weight, a very heavy suitcase, and instead of being able to lift that weight, the muscle, instead of contracting, relaxes, and that weight falls from your hand. That is known as an inverse stretch reflex. Now, what happens in the inverse stretch reflex? Whenever there is an increase in muscle tension, now the Golgi tendon organ is excited. Where is the Golgi tendon organ located? It is located in the tendons, right? Tendons. Now, the sensory fiber from the Golgi tendon organ is 1B, yes? Then sensory fiber from the Golgi tendon organ is 1B. It enters into the spinal cord, yes? It enters into the spinal cord. It enters into the spinal cord. And now it synapses with an inhibitory neuron. It synapses with an inhibitory neuron. And this inhibitory neuron will inhibit the A alpha, which goes towards its same muscle. And what is going to be the response? Response will be a muscle relaxation. So instead of A alpha being excited, now that A alpha is inhibited, and this is a muscle relaxation. Here, the 1B fiber will excite this inhibitory interneuron which is present, which in turn inhibits the A alpha, which goes towards that particular muscle, and that muscle will now relax, and that is how that weight will fall from your hand. It is an inverse stretch reflex, right? Inverse stretch reflex. Like you must have seen this in, let's say, if you're watching Olympics on the television or Asian Games. Here is the weightlifter trying to lift 175 kgs or something. Yes, instead of being able to lift that weight, that his muscles relax and that weight falls from his hands. That is because of the inverse stretch reflex. Yes. What is this inverse stretch reflex? In fact, the inverse stretch reflex is protective. This is a protective mechanism, isn't it? This is a protective mechanism. Why do we call it protective? Because it is protecting. It causes a muscle relaxation. It protects against a avulsion of the tendon. If the muscle tension increases, it becomes very high in a muscle, there can be avulsion of tendon. So this is protective against that. It is protecting against an avulsion of the tendon. Yes. So what happens is there is a muscle relaxation. Yes, this is a type of a feed-forward reflex, feed-forward mechanism, feed-forward inhibition. You understood? So this is what happens is the MB psychotic arm wrestling. Yes, maybe this is the inverse stretch reflex, protective mechanism, right? Protects against an avulsion of the tendon. Yes, it is like a feed-forward mechanism. A stimulates B, but B inhibits C. Right? So this is as far as your inverse stretch reflex is concerned. So please remember, stimulation of the Golgi tendon organ, stimulation of the Golgi tendon organ will produce a muscle relaxation. Stimulation of the Golgi tendon organ will produce a muscle relaxation. Yes. And when does the Golgi tendon organ get excited? Whenever there is a huge increase in muscle tension, right? A huge increase in muscle tension. Have we cleared that? Right? This is a huge increase in muscle tension. Okay? Now, another important point. Golgi tendon organ, whenever it is excited, it will produce a muscle relaxation. Golgi tendon organ can respond to increase in muscle. It can also respond to an excessive stretch. Right? Stimulation of the Golgi tendon organ can occur whenever there is a massive increase in muscle tension, or if there is an excessive stretch. If there is an excessive stretch. Remember, if it is a mild to moderate stretch, the muscle spindle response will happen. There is stimulation of the muscle spindle and the response will be a muscle contraction. But if the stretch is excessive, if there is an increase, then it will be the stimulation of the Golgi tendon organ and a muscle relaxation, right? Muscle relaxation. So two important points here. Golgi tendon organ. Golgi tendon organ responds to increase in muscle tension or stretch. My answer is increase in muscle tension. But if there is an option of both, then you will have to go for both. Have you understood? If it is between the muscle tension and stretch, then my answer is muscle tension. But if there is an option of both, then your answer is both. Second important question. Threshold of the Golgi tendon organ. Golgi tendon organ to stretch. Is it low or is it high? Remember, the stretch has to be excessive. So threshold of the Golgi tendon organ to stretch will be high. It responds to both muscle tension and stretch, but the stretch has to be excessive. Stretch has to be excessive, which is responsible for which will stimulate the Golgi tendon organ. And whenever the Golgi tendon organ is stimulated, this will result in a muscle relaxation. So this is your inverse stretch reflex, which is a bisynaptic reflex. Okay? If it's a mild or moderate stretch, the muscle spindle will get excited. If it is an excessive stretch, then Golgi tendon organ gets excited. Right? So this was your stretch reflex and inverse stretch reflex. Which are the polysynaptic reflexes? Which are the polysynaptic reflexes? Polysynaptic reflexes, like I said, most reflexes are polysynaptic. Most reflexes are going to be polysynaptic. Yes? Most reflexes are polysynaptic. Most reflexes. Examples of polysynaptic spinal reflexes, for example, the flexor withdrawal response. Flexor withdrawal response. This is a polysynaptic reflex. Flexor withdrawal response. Painful stimulus. There is a withdrawal of that limb. Flexor withdrawal response. It is a polysynaptic reflex. Crossed extensor response. Crossed extensor reflex. cross-extensor reflux. If stimulus is very painful, this will result in a flexion of that limb. And there is a flexion of that particular limb plus extension of the opposite limb. Flexion of that limb and extension of the opposite limb. So that is known as the crossed extensor response. These are all examples of polysynaptic spinal reflexes, right? These are polysynaptic and spinal. The center for these reflexes are the spinal cord. Flexor withdrawal response, crossed extensor response. These are reflexes. Micturition reflex. Micturition reflex is a polysynaptic and spinal reflex. Whenever the bladder distends, there is a reflex contraction of the detrusor. The sensory fibers from the bladder go towards the spinal cord. From the spinal cord, motor fibers to the detrusor muscle. Yes, so that is micturition reflex. Then even the defecation reflex. This is also a polysynaptic and a spinal reflex. Then please remember, these are spinal reflexes. These are spinal, but with higher center control. Isn't it? Higher center control means you wait for there is a higher center control. You wait for an appropriate time and place, right? Appropriate time and place. So that is what is higher center control. Okay? Micturition reflex, defecation reflex. Sexual responses. These are also sexual responses. These are all polysynaptic and spinal reflexes, right? So which are the polysynaptic? These are just examples, right? Flexor withdrawal. You touch something hot, there is a flexion of that limb. That is flexor withdrawal. It's a polysynaptic and a spinal reflex. What is crossed extensor? If stimulus is painful, that limb will flex, opposite limb will extend. This is very prominently seen in animals. Crossed extensor is prominent in animals, not so much in us, but definitely it is prominent in animals. There is an extension of the opposite limb. Micturition reflex. When the bladder is distended, contraction of detrusor, relaxation of the sphincters, micturition reflex, defecation reflex, sexual responses. These are all polysynaptic and spinal reflexes, but with a higher center control. Okay? Higher center control. Okay? Flexor withdrawal does not go to the cortex. Flexor withdrawal is a spinal reflex. Please be very careful. Flexor withdrawal is a spinal reflex. Okay? Flexor withdrawal does not go to the cortex, Harshita. It's a spinal reflex. Polysynaptic and spinal reflex. Okay? So all of these are polysynaptic spinal reflexes. These are examples of polysynaptic and spinal reflexes. Polysynaptic spinal reflexes. Okay? All right. Yeah, then. Okay. All right. So you can take a break for 15 minutes. See you at 6:25, 6:40 p.m. Okay.